This is the PowerPoint recording for microsurgery for cerebral cavernous malformation by Dr. Russin, Dr. Renard, and Dr. Spetzler. The objectives are to depict the common presentations on MRI scan and CT scan, to provide the appropriate indications for treatment, and to provide planning for specific approaches. Cavernous malformations are angiographically occult, thin-walled vascular lesions. Although late in the angiographic phase, venous puddling may occur. They occur in both sporadic or familial form, and their incidence is as depicted on the slide. Their most common manifestation are seizures because of the leakage of hemosiderin on the cavernous malformation and their propensity to bleed. They can also proceed with hemorrhage, headaches, and focal neurological deficits. CT scans are nonspecific as they depict basically hemorrhage. The MRI scan, on the other hand, with its classic popcorn lesion and heterogeneous center, is diagnostic. Angiography is only indicated if there is uncertainty in the diagnosis. Surgical indications: there are no appropriate medical or radiation treatments, so microsurgical resection is appropriate based on the clinical presentation and the location of the cavernous malformation. Asymptomatic lesions can be considered for resection if they are in non-eloquent areas where the surgical risk is very low and where the cavernous malformation has shown a propensity to grow. Those that are deep, eloquent, really should only be considered for treatment if they've had multiple hemorrhages or a progressive neurologic deficit. Surgical approach can be assisted by utilizing the two-point method, which is putting a point in the center of the lesion and one where the entry point is the most suitable or the closest to the surface of an eloquent structure, and then combining those 2 points with a straight line and where it exits the skull, utilizing that approach. The goal is complete surgical resection with preservation of any associated venous anomaly. When complete resection has been achieved, the risk of recurrent hemorrhage becomes less than 1%. Cavernous malformations in the brainstem or very eloquent areas carry a high risk of temporary worsening in the 30 to 60% range, although these deficits can be expected to improve significantly in the vast majority of patients. An overview of decision-making and indications for surgery are presented. A retrosigmoid approach is pictured providing access to the appropriate areas on the medulla, pons, and middle cerebellar peduncle. A park bench, lateral, or concord position can all be used. On rare occasions, some surgeons utilize a sitting position as well. Some beautiful pictures of the exposures that can be achieved with the retrosigmoid approach. The far lateral approach, which is a workhorse for access to the lateral portion of the medulla and the anterior portion of the brainstem and the high cervical cord. The importance of utilizing a lateral straight or lazy S incision is that the muscle mass that is in the way with the midline incision is avoided. The degree of resection of the condyle depends on the need for access anteriorly on the brainstem. Supracellular approach is depicted. The supracellular approach is a very nice way to the pineal region, and when combined with a lateral supracerebellar or far lateral supracerebellar approach and with the ability to cut the tentorium, a large area of the deep structures can be accessed in a fashion that avoids going through the brain. A lateral supracerebellar infertentorial approach for a cavernous malformation in the thalamus is depicted. Interhemispheric transcallosal approach is an approach that is robust and allows a large area of exposure for midline and near midline lesions. Having the head elevated 45 degrees and in the horizontal position, which can be accomplished by rotating the operating room table, and a support for the shoulder, allows the utilization of your hands and eyes in the most comfortable position, and with the sagittal sinus parallel to the floor, gravity can be used to retract the ipsilateral hemisphere. An example of a cavernous malformation located in the thalamus that is approached through a contralateral interhemispheric transcallosal exposure. So in summary, the MRI scan is the test most appropriate for getting a diagnosis, and the decision and indications for surgery are based on the clinical presentation and anatomical location of the lesion. Thank you.